Greetings and welcome, everyone. Somehow we seem to have a little bit of problem with playing the team. Sorry for that. Well, today is the first Journal Club with Authors episode, and this is a definite must-watch episode for anyone who receives a salivary gland specimen bottle and thinks to themselves, "Oh God, let there be enough tissue." That's a something we very often face, and I think today's Journal Club is really going to help with that. For everyone who is new, I'm Dr. Mandana Donahue. I'm the founder of Oral Pathology 360, and Oral Pathology 360 is the home of everything in oral and maxillofacial diagnostics on the web. And we hope to bring you education, collaboration, and expertise when you need it, where you need it. But today's episode, I should say, is really not my work. It's thanks to Dr. Pouyan Aminishakib, who is a new addition to our team. He is an honorary member of the team now, and he is the one who will be bringing you this event every month. It's his idea, it is his show, and I will only be helping. And thank you so much, Dr. Pouyan, and welcome to the team.
Okay, thank you. Thank you for supporting us for holding this program. Uh, Thank you again, Dr. Mandana, and I would like to appreciate Oral Pathology 360 for the support. It's a great pleasure for me to start the first online journal club focusing on the salivary gland neoplasm in small biopsies and fine needle aspirations. It's a great pleasure for me to host Professor Zubair W from Pennsylvania University and also Professor Hana Saffar from Cancer Institute Hospital. At the beginning, I would like to give you a short introduction of Professor Baloch. Professor Baloch received his medical degrees from Hyderabad of Pakistan. After receiving his PhD in 1991, he joined the pathology residency, and this was followed by fellowships in surgical pathology at Memorial Sloan Kettering Cancer Center in New York and cytopathology at the University of Pennsylvania Medical Center, Philadelphia. Dr. Baluch began his career as an assistant professor in the Department of Pathology and Laboratory Medicine at the University of Pennsylvania Medical Center in 1997, and he's currently a professor of pathology and laboratory medicine there. He has authored more than 300 peer reviewed publications in leading pathology and endocrine journals on the subject of endocrine and head and neck pathology and book chapters. Dr. Baluch has delivered numerous lectures, workshops, and short courses both at the national and the international meetings, and he has co authored three books and has served as co-editor of the most recent Milan system for reporting salivary gland cytopathology. Thank you, Professor Baluch, for accepting my invitation. And also, I would like to thank Professor Saffar for accepting my invitation. She kindly support us to hold these programs. And also, we have two talented residents from Cancer Institute Hospital, Dr. Maryam Hosseinirad and also Dr. Parisa Mohammadi. The common program including two separate part. At the first part, our resident Dr. Maryam will present the first section of the paper I explained earlier, and after a short discussion, we will have the second presentation by Dr. Parisa, and then we will share your questions and our idea with the author of the paper, Professor Baluch. Okay, Dr. Baluch, Dr. Safar, do you have any comments?
No, I am actually honored um, to really be joining this broadcast. Um, and thank you so much for the invite. And thank you for highlighting the the publication that I wrote with Dr. Jalali, who's also a head and neck pathologist at my institution. And thank you again. I mean, I'm really happy to be joining this virtually. Thank you.
You're welcome. The honor is ours. And Dr.
Hello,
Saffar,
hello
please.
everybody. Thank you so much. It's really a pleasure for me to participate and thank you for invitation in your eminent group. Thank you, Dr. Baloch. It's really a pleasure for me to be in this presentation. Thanks to my dear colleagues, Dr. Hosseinirad and Dr. Arab Mohammadi, for their participation. And also, I want to clarify that I'm not a head and neck professor. I'm just an anatomical surgical pathologist interested in head and neck pathology, and I'm not a professor. I'm just associate professor of pathology because we are all discussing with an eminent professor like Dr. Baluch. I think it's really needed to clarify these things. Thank you so much.
Okay, thank you very much. And Dr. Manda, now we are ready for hearing and watching the first video.
Hi to everyone online watching us. My name is Maryam Hosseinirad. I am currently a third year pathology resident at Tehran University of Medical Science. It's a great pleasure to be here among you, dear colleagues and professors. I'm so delighted to present to you today. This presentation is designed to share a review article titled as Salivary Gland Neoplasms in a Small Biopsies and Fine Needle Aspirations by Professor Jalal Jalali and Professor Zubair W. Here is the outline of my presentation. First, I will give an overview of the paper. My presentation consists of the first half of this paper, which includes epidemiology of salivary gland neoplasms and clinical presentation, FNA and core biopsies method, review of basaloid neoplasms. Salivary gland neoplasms, which are uncommon but diverse tumors in the head and neck, present diagnostic challenges. Limited cellularity specimens, often with overlapping clinical and imaging features, make their diagnosis tricky. Fine needle aspiration and core biopsies are commonly performed before surgery. These procedures provide crucial information to guide clinical management, including surgery. While these preoperative procedures are highly sensitive in confirming primary neoplasia, assessing tumor grade, and ruling out non-surgical disease, they may not always give a definite diagnosis. This is especially true when dealing with limited specimens. And despite these limitations, these diagnostic methods play a vital role in shaping treatment strategies. In this part, I explain the epidemiology of these tumors. Salivary gland neoplasms, which are rare and make up only 3 to 10% of all head and neck neoplasms, have a low annual occurrence of about 0.3 to 13.5 cases per 100,000. Even though they are not common, these tumors are incredibly diverse, causing a variety of growths in a single organ or tissue. The WHO, the WHO recognizes many different types of salivary gland neoplasms, and this list keeps growing. One of the challenges in dealing with these tumors is that they can look very similar, making it hard to tell non-neoplastic, benign, and malignant lesions, especially when we have only small samples to work with. And knowing the relative frequency of different types of tumors is essential. It helps us come up with a list of possible diagnoses and improves our ability to accurately diagnose. Let's delve into the characteristics of salivary gland neoplasm and understand the difference between benign and malignant tumors. 70 to 80% of salivary gland neoplasms are benign, which are majority of salivary gland neoplasms, especially those originating in major salivary glands. And pleomorphic adenomas are the most prevalent neoplasms among both adults and children, which affecting major and minor salivary glands. In contrast, around 50% of tumors occurring in minor salivary glands are malignant. The most common malignant tumors are mucoepidermoid carcinoma and adenoid cystic carcinoma, collectively accounting for approximately half of all malignant salivary gland neoplasms. And let's explore the distinct preferences of certain tumors for major and minor salivary glands as outlined in Table 1. Recognizing these preferences is crucial for accurate diagnosis and targeted treatment strategies. Let's take a closer look at these specific tumor types and their distinctive characteristics. As seen, Table 1, neoplasms preferentially affecting major glands consist of basal cell carcinoma, basal cell adenoma, and adenocarcinoma, Warthin tumor, actinic cell carcinoma, lymphoepithelial carcinoma, and cyeloblastoma. And tumors arising in minor glands include canalicular adenoma, and plomorphous adenocarcinoma, microsecretory adenocarcinoma, sclerosing microcystic adenocarcinoma, and hyalinizing clear cell carcinoma. Let's explore how patients often become aware of salivary gland neoplasms and different ways these tumors manifest. Patients often discover salivary gland neoplasms themselves, either during self-examination or through clinical or through a clinician, often a dentist. These tumors can also be found incidentally during imaging of a head and neck for unrelated disease. Most patients with major salivary gland neoplasm notice a swelling or distinct mass in the neck, often the sole symptom in benign cases. Often symptoms such as and other symptoms such as pain, numbness, or facial paralysis are more common in malignant cases. The clinical presentation of minor salivary gland neoplasms varies based on the location. Symptoms can range from asymptomatic mucosal swelling to obstructive symptoms caused by compression of nearby structures. Ultrasound is an initial and essential step in assessing neck masses. It's easily accessible and helps confirm the presence of a mass within the salivary glands. Ultrasound also provides information about the masses composition, solid versus cystic, margins, invasiveness, and regional lymph node status. Salivary gland neoplasms typically appear hypoechoic against the hyperechoic background of the salivary gland parenchyma. For deep-seated lesions or those obscured by bone, CT or MRI examinations are more effective. MRI in particular excels in evaluating the invasiveness of a tumor. The increased use of PET scans in cancer staging has led to incidental findings in various body regions, including the salivary glands. Incidental PET positive masses in parotid gland are often benign, with Warthin tumor being a common finding, although metastasis is also considered in a differential diagnosis. Now let's discuss the crucial role of fine needle aspiration and core biopsies in sampling salivary gland neoplasms. The choice between FNA core biopsy or a combination depends on the practice followed by the radiology and pathology departments, in particular institution. FNA is a common method with high sensitivity, 96% in detecting neoplasms. While it is effective, the detection rates for malignancy range from 75 to 87.6%. FNA is highly specific, more than 90% for both neoplasms and malignancies. And core biopsies have a higher sensitivity for detecting malignancy compared to FNA. The specificity is relatively similar to FNA. However, the use of larger gauge needles in core biopsies may lead to higher complication rates. Having rapid on-site evaluation during the procedure can enhance the utility of core biopsies in selected cases. And now let's explore the Milan system for reporting salivary gland cytopathology, or MSRSGC, a global initiative aimed at standardizing the diagnosis of salivary gland lesions. The Milan system, introduced in 2018, is an international system developed by co-authors from 15 countries. Its purpose is to establish a common language and set of categories for diagnosing salivary gland lesions. And the primary goal of the Milan system, or MSRSGC, is to enhance communication among clinicians and institutions. By using standardized terminology and categories, the system aims to improve overall patient care. The second edition, published by July 2023. As you see in Table 2, the Milan system has 6 main diagnostic categories, each associated with a risk of malignancy, including non-diagnostic category, non-neoplastic, ATB of undetermined significant, and neoplasm category, that is split into benign and salivary gland neoplasm of uncertain malignant potential, and suspicious for malignancy category, and malignant category. Now let's discuss the multifaceted challenges encountered in interpreting salivary gland cytopathology specimens and small biopsies. Salivary glands present a unique challenge, as a number of distinct benign and malignant neoplasms likely exceeds that of any other organ. This list is continually expanding, adding to the complexity. Many neoplasms exhibit a significant morphological and immunohistochemical overlap, distinguishing between benign and malignant without detailed histologic examination of the tumor's capsule or periphery is challenging. The absence of tissue architecture in cytology and the limited evaluation of the tumor or stromal interface in core biopsies contribute to the complexity of interpretation. Malignant transformation in benign neoplasms may be focal and not adequately represented in limited specimens, further complicating accurate diagnosis. Adopting a morphological pattern-based approach that considers cell features and architectures become crucial in navigating the differential diagnosis and enhancing diagnostic accuracy. Low power impressions capturing the overall color of tumor cells can play a significant role in guiding the subsequent steps of diagnosis. Let's explore the characteristics of basaloid neoplasms, which often present distinctive features. Basaloid neoplasm typically appear blue at low magnification. Many basaloid neoplasms are biphasic, consisting of both epithelial and ductal and myoepithelial or basal cells. Some are also matrix producing neoplasms. The quality of the matrix can impact the risk of malignancy in basaloid neoplasms. Previous studies indicated that basaloid neoplasms with fibrillary stroma or matrix have a low risk of malignancy compared to those with non-fibrillary stroma. However, the presence or absence of non-fibrillary stroma or matrix doesn't influence the risk of malignancy. Pleomorphic adenoma, a benign mixed tumor, serves as an example of benign matrix producing salivary gland neoplasms. Figure 1 is pleomorphic adenoma. In picture A, And diff quick stain shows a fibrillary metachromatic matrix with embedded myoepithelial cells. Picture B demonstrates a less pronounced matrix on papanicula stain appearing light blue to green. H&E stained tissue sections show a chondromyxoid matrix with ductal and numerous myoepithelial cells. In cytology, SMEs, the matrix is fibrillary and magenta or metachromatic with diff-quick stains, often described as having a feathery or troll hair-like appearance, as you can see in figure 1a. And plasmacytoid to spindle shape myoepithelial cells are embedded in a matrix showing occasional intranuclear pseudo-inclusions. Diagnostic biopsies reveal an abundant loose chondromyxoid matrix with a mix of ductal, myoepithelial, and stromal cells, as you see in figure 1c. Now let's explore the challenges in diagnosing pleomorphic adenoma and its differential diagnosis. Several examples of pleomorphic adenoma can be diagnostically challenging. The differential diagnosis often involves distinguishing it from basal cell adenoma or adenocarcinoma, adenoid cystic carcinoma, and other low-grade myoepithelial-rich neoplasms. A recent multi-institutional study found that the risk of malignancy remains low when a pleomorphic adenoma is part of the differential diagnosis. The risk is similar to cases categorized as Milan system category 4A. Referring to the table from the Milan system for reporting salivary gland cytopathology, cases of pleomorphic adenoma fall under the benign or 4A category. To narrow the differential diagnosis, demonstrating PLAG1 or HMGA2 rearrangement through FISH analysis can be valuable. However, it's important to note that this analysis doesn't exclude malignancy, as epithelial myoepithelial carcinoma frequently harbor the same fusions. Now, let's turn our attention to adenoid cystic carcinoma, a distinctive salivary gland neoplasm with unique characteristics. Adenoid cystic carcinoma is characterized by a dense and globular matrix as depicted in figure 2. In picture A, the diff-quick stained SMEs reveal a globular and dense matrix. Picture B illustrates neoplastic cells arranged around the matrix in cribriform architecture. While the matrix may not be easy visualized in papanicula stained SMEs that indicated by arrows, the cribriform architecture remains visible. And this staining method allows for better appreciation of nuclear chromatin details. Now let's delve into the distinctive features of polymorphous adenocarcinoma, a basaloid tumor that shares some architectural similarities with adenoid cystic carcinoma. The cribriform architecture, often associated with adenoid cystic carcinoma, may also be focally seen in other basaloid tumors such as pleomorphic adenoma and polymorphous adenocarcinoma. And in figure 3a, the tumor cells in polymorphous adenocarcinoma have a clear and papillary thyroid carcinoma-like nuclei, contrasting with the angulated and hyperchromatic nuclei seen in adenoid cystic carcinoma. And figure 3 reveals polymorphous adenocarcinoma as you see in picture A in limited specimens. The cribriform architecture associated with matrix may lead to an erroneous diagnosis of adenoid cystic carcinoma. Additionally, in picture B, focal areas may have overlapping features with polymorphous adenoma. The swelling low magnification appearance in picture C and this cordant P63 in picture D and P40 in picture E expression along with foci of perineural invasion in picture F and G confirms the correct diagnosis. Adenoid cystic carcinoma is usually positive for P63 and P40, while polymorphous adenocarcinoma is positive for P63 and negative for P40. And the discrepant P63 and P40 profiles are also observed in microsecretory adenocarcinoma, a recently described entity. Thank you for your attention.
Okay, thank
Yes.
you very much. Great presentation by Dr. Maryam. And let's directly go to discussion panel. Dr. Baluch, let me get started this part with a general question. If final aspiration biopsy a reliable approach to differentiate malignant salivary gland tumors from benign salivary gland lesions?
Um, well, first of all, thank you for inviting me to this discussion. Um, I think when you look at the limited cellularity specimens, the best answer is achieved when you're asking the which question you are asking. So if you ask a question that the malignant tumors versus benign tumors, so you are already in a neoplasm category, right? So you're asking whether this is a benign neoplasm or it's a malignant neoplasm. When it comes to the most common malignant tumors, like mucoepidermoid carcinoma, or you're talking about actinic cell carcinoma or adenoid cystic carcinoma, and they have their features are very well described. And thank God, they're also the most common tumors, right? Now, the minor salivary glands, there is more of a heterogeneity, right? Because there is a lot of overlap. But what one has to think about that when you're looking at a biopsy, you have to create what I call as food groups. So is it so you have to have this checklist. Is this a basaloid tumor? If it's a basaloid tumor, is it a monomorphic basaloid tumors? Because as we know with adenoid cystic carcinoma, there's not much nuclear pleomorphism, right? They all look the same in a classic case, unless it's a high grade one with a solid growth pattern. One also has to really be careful and get as much information as possible. The clinical features, the how does it look on ultrasound? How does it look on radiology? Is it a circumscribed tumor or it has infiltrative margins? So keeping those in line, I think if you look at the most common malignant tumors, naturally we can diagnose on cytology or limited cellularity specimens. The other thing is, one also has to think about that it's not always black and white because the tumors, I always say, do not read atlas or they do not read chapters that are beautifully written. They have beautifully illustrated examples. But as we know, when we practice everyday cytology or everyday biopsy pathology, that does not happen, right? Because there's a lot of heterogeneity. So even if you look at the myoepithelial cells, they are seen in many tumors, right? Oncocytic cells or oncocytic metaplasia is seen in many tumors. Stroma can be very problematic. Stroma can be part of the tumor, or when the tumor is infiltrating, and if you put the needle in that area, that stroma, which does not belong to the tumor, will mimic as a part of the stroma of the tumor, right? So I think when you're creating a differential diagnosis, you have to take everything in thing. And if you cannot make an exact diagnosis for those common tumors that you see, then you can actually provide a different. And the differential, a lot of my surgeons at Penn always tell me that is very helpful because how do you push the low grade or the benign neoplasms on the top of the differential matters, because then their conversation with the patient is what type of surgery they are going to do. If it's parotid, if they are going to be sacrificing, or if the damage to the facial nerve is going to happen. When you're in the minor salivary gland, what type of surgery they are going to do, depending upon patient's age and if they have other comorbidities. So I think we are actually, this era of small biopsy pathology is very exciting currently, but also understand that the screenings have gone up, right? So we are picking up a lot of these smaller tumors, and majority of them are benign. Naturally, minor salivary glands have a higher rate of malignant tumors. So you have to do the best by really first really honing down, is this a classic case? If it's not a classic case, what else can it be? And my mentor, one of my surgical pathology mentors, was late Dr. Juan Rosai, who was at Memorial. And he always told me that as a trainee or as a pathologist, when you start your differential, start from low. Let's start from non-neoplastic and benign and then go up towards malignancy. Because if you start from malignancy, it's very hard for the mind to come down to the benign. So I think what you have to understand, what the question is being asked, it's not black and white, and you can do the best you can by really looking at what is the dominant cell type there is. I hope I answered your question.
Great. Thank you very much for your answer. And Dr. Saffar, do you have any comment or question to share with us?
Thank you so much, and thanks again, Dr. Professor Baluch. Dear Professor, if it's possible, I want to ask from the beginning, step by step. For example, for first of all, in my country, in Iran, in some universities, surgical pathologists prefer to take the FNA specimens themselves in surgical pathology department. But in others, as ours, for example, specimens, we receive the specimens from head and neck surgeons or from the radiologists, you know. In your experience, do you prefer to take the specimen yourself, particularly from major salivary gland specimens like parotid, or you prefer to receive it from a radiologist or a head and neck surgeon?
So I think so. Let's say there is a 85-year-old woman. I'm just going to give you an example. She has history of breast carcinoma, and now they found this little mass by the dentist is found, and the dentists are the most commonly find these masses, right? She comes in, and this mass is very mobile. It's in the parotid superficial gland, and on the initial impression is that this is just a small, pleomorphic adenoma. I will go in, put a needle, and biopsy it. But for me, for the other tumors, cystic and solid tumors, the tumors that have associated with some kind of clinical symptoms like pressure or pain, or they're causing some form of other functional defects, I would like that specimen to come from by under guidance. At the
Mhm.
same time, even the cytologists now or cytopathologists now are doing biopsies under ultrasound guidance. I think the ultrasound guidance provides, first of all, the needle placement. If it's a mixed cystic and solid mass, which could be because of tumor necrosis, or it's the tumor which, like wharton, it has, and wharton is very commonly picked up because whartons are PET positive tumors, and when you're being screened for other tumors, that tumor lights up, right? So for me, that needle placement in the solid areas, and you're not just getting the junk. Now, the infiltrative edge, they can take a sample from the infiltrative edge, because that will be the most funny looking stuff. So, and when you're doing the needle by yourself, you kind of try to stay in one area or go a little bit, but when you're doing the under guidance, the needle can go and take samples from different areas, because as we know, salivary gland tumors, especially when you're talking about tumors that have stroma, can be very heterogeneous from field to field, and that heterogeneity cause lot of cytomorphologic overlap. So for me, that's very important. So I personally prefer, even for the lesions that are palpable, but they're associated with some form of symptoms, I like at least a radiology to give me an idea what type of things we're dealing with, because radiologist also gives you a good differential, which is always helpful.
Thanks a lot for your explanation. And about the staining, what is your routine in your department, Professor? For example, you prefer to have all the slides in pop or you prefer to divide them to two parts, some in pop and some in diff quick stains for evaluating matrix or cytoplasmic material? What is your routine and what is your experience and recommendation for us?
So I think I personally, I believe, because I have, a lot of experience, and with my age, I believe the best practice is the practice where there is a mix of basic concepts of the old and new. I think that provides the best um, pathologic diagnosis. Plus, it provides the best training for our trainees, right? The incoming generations. So we go on site. We have a team that goes on site, and I still like the Romanovsky stain on an air dried slide. You give me an idea about the matrix, about the cellularity, about the adequacy of the specimen. And by looking at it, you can tell that this specimen is going to be the one which is not going to be a clear cut pleomorphic adenoma or a Wharton tumor or something like that, or a Senex cell. And then by doing that, you can get extra passes and collect it for additional studies, because there is good immunohistochemistry or fishes available where you can diagnose most of these tumors and provide a targeted diagnosis. So we have basically a diff quick. So we always do two smears from at least first two passes, and the other one is fixed in alcohol for pap stain, and the rinse goes into a cup where we do either a cell block or a thin prep from it. So for me, that is very, very helpful. So I think that is the optimal type of preparations that really, and if I need a core biopsy, I'll tell them, you also need to core, because that will really, and that is looked by us also. So I think it really kind of brings down, I think it's optimally how you can manage these specimens. So that's what we do.
Thank you so much.
Okay.
Dear Dr. Pouyan, do we have time to ask questions, or it's better to postpone it to the next discussion?
Okay. Okay, because of time shortage, if you would let us, we can share a few questions from the audience. One of our participants asked Professor Baloch, do you have any idea why the benign tumors are more common in major salivary glands and the malignant ones are more common in minor salivary glands?
Um, I think I personally really, I do not have a scientific reason for that. I personally think because the major salivary glands are so open, right? You can see them and you can palpate them. So there is a lot of, the benign tumors naturally, there's more there, correct? And I think it varies by diagnosis and incidence. Oropharyngeal area is a big area, right? So if there's a benign tumor growing in there, and most of these benign tumors don't grow pretty fast, the patients may die with that small benign tumor in one of the minor salivary glands in the oropharyngeal area. So, and then they stay. So I think it's all, I personally think it's a matter of incidence and the diagnosis and how that's why I think you see that incidence of benign tumors. I think there is some truth to that, but I just think it's also there's a factor of diagnosis. But at this point, I will be honest, I do not have a scientific explanation for that.
Okay, thank you for your reply. And the next question from Professor Hill. Thank you, Professor Hill, for joining us. The question is about that can you highlight the major differences between traditional cytosmear and liquid-based cytopreparations?
So I think it's a learning curve. Traditionally, how you are taught, it's important. So what happens, if you look at the monolayer preparations, they were prepared, they came into trend first because they were made for pap smears, right? We wanted to get rid of inflammation, we wanted to get rid of the background, and they were really geared towards squamous cells, the hardened cells which are not affected by preparation, right? And so naturally you had a monolayer preparations, and you saw all these squamous cells, and you can diagnose all these high grade lesions that we were supposedly missing on conventional smears. For me, the background really matters. And I think that background gets minimized or taken away, like inflammation and stuff on a monolayer preparations. So there are, as we know, there is a lot of cases of chronic sinusitis that mimic tumors because they become very basaloid. They can go under squamous metaplasia or even oncocytic metaplasia. So that inflammatory component gets away on the monolayer preparation. So that's why I think it's a learning curve. The stroma of the beautiful stroma that you see in pleomorphic adenoma, the lymphocytes that you see in Wharton tumor, that mobile oil consistency that you see on an FNA from a Wharton tumor, or even that stroma, ball-like stroma, which has beautiful magenta color of adenoid cystic that you see on the smears in the monolayer preparations, that actually gets sometimes lost and you just have these empty spaces. So I think it's a learning curve. You have to be careful because monolayer preparations have preparation artifacts. The edges of it gets very air dried and the cells blow up. So I think it's a learning curve. I personally like everything. I like smears plus monolayer preparation because it's a good learning for me and also active. But in the same token, if a surgeon or if somebody else is making smears and they are not good smears, then you're losing the specimen. So in those cases, I will say just put it in the cup, give me, and I can make a cell block and monolayer preparations from it. So I think it's a everything really matters, and I think it's good if you have a combined, but it's doable. Monolayer, you have to teach yourself.
Okay, thank you very much for the explanation. Dr. Mandana, I think it's time to go to the second video.
The second group of morphologic patterns we see on salivary gland specimens is oncocytic pattern, which appear pink to clear at low magnification. Here we listed benign and malignant neoplasms with this kind of pattern. Among them, you can see Wharton tumor, which is the second most common benign neoplasm in salivary gland. As you can see in the picture, classic examples of Wharton tumor show biphasic oncocytic epithelium with papillary architecture and lymphoid tissue in the cores of the papillae. A papillary fragment is demonstrated in this diff-quick stain smear on the right, containing oncocytes and lymphoid tissue cores, as well as a cluster of oncocytes on the left. Here you can see some pop stain smears, which show oncocytes and scattered lymphocytes in the background. And finally, a resection specimen, which shows biphasic morphology, which we discussed earlier. There are two other benign neoplasms, including oncocytoma and oncocytic cystadenoma, which are also composed of oncocytic cells, but with no lymphoid tissue in cytology specimens. The next tumor in this category is mucoepidermoid carcinoma. It's the most common malignant salivary gland neoplasm, which morphologically is composed of three kinds of cells, including mucinous, intermediate, and epidermoid cells. Intermediate and epidermoid cells usually have a relatively abundant cytoplasm, which appear oncocytoid or squamoid at low magnification, as you can see in these pictures. Low-grade mucoepidermoid carcinomas usually have more background mucin and more easily found mucocytes. This quick stain smear on the right shows this abundant mucin in the background, but in contrast, higher grade lesions usually predominantly show intermediate and squamoid cells. Now notice the sharp edges in squamoid clusters in these cytologic specimens. Also, several variants have been introduced for mucoepidermoid carcinoma. An example is Warthin-like variant. In this variant, you can see focal Warthin-like features in an otherwise typical mucoepidermoid carcinoma. This variant may be misdiagnosed as Warthin tumor. Another oncocytic malignant neoplasm is actinic cell carcinoma. This tumor is cellular on cytologic smears composed of uniform round and hyperchromatic nuclei with abundant granular cytoplasm. It may be seen in solid microcystic papillary or follicular patterns. Secretory carcinoma should be considered as a differential diagnosis for actinic cell carcinoma when cystic foci oncocytoid tumor cells and luminal secretions are seen in the specimen. Hopefully, IHC and molecular studies are helpful to distinguish these two neoplasms, while actinic cell carcinoma is positive for DUG1 and NR4A3. Secretory carcinoma is positive for GATA3, S100, and momoglobin. Also, presence of ETV6 rearrangement is seen in secretory carcinoma. In these Diff-Quick and pop stain smears, you can see some clusters of uniform tumor cells with oncocytoid granular cytoplasm, and histologic examination confirms the diagnosis at the end. Salivary duct carcinoma has also oncocytoid cells arranged in cords, trabeculae, or small nests. In this high-grade lesion, necrosis is a feature frequently seen associated with intraductal components. The necrosis with nuclear debris are seen in the picture on the right. Morphological overlap exists with invasive ductal carcinoma of the breast. However, in contrast to invasive ductal carcinoma, salivary duct carcinoma never co-expresses ER and PR. Here you can see neoplastic cells in detail, which highlights the degree of variability in nuclear chromatin and occasional prominent nuclei. In hyalinizing clear cell carcinoma, tumor cells can be clear to oncocytoid, which are arranged in cores and clusters in a hyalinized stroma. There are also some other less common salivary gland neoplasms with oncocytic cytology, including oncocytic myoepithelioma or carcinoma and oncocytic epithelial myoepithelial carcinoma. Many salivary gland neoplasms have characteristic molecular aberrations, some of which are relatively disease specific. However, specificity of some molecular aberrations may be in question. This table shows molecular aberrations in primary salivary gland neoplasms, and specific ones are shown in bold, such as CTNNB mutations for basal cell adenoma or MAMEL1 and MAMEL2 for mucoepidermoid carcinoma. It's well understood in cytology smears and biopsy sections a definitive diagnosis cannot be rendered, especially in limited specimens. Now, here we discuss some scenarios which help with clinical decision making. Some non-neoplastic conditions can mimic malignancy. For example, squamous and mucinous metaplasia, which may occur in inflamed salivary gland, can mimic mucoepidermoid carcinoma or squamous cell carcinoma. Necrotizing myelometaplasia is one of the examples. This tumor can be distinguished from malignant neoplasm by well-circumscribed and non-invasive appearance. However, it is almost impossible to evaluate in FNA or small biopsies. In this picture, you can see metaplastic ductal structures with nuclear overlap and a bland nuclear feature, which may be confused with malignant neoplasms. Squamous metaplasia is a more common diagnostic pitfall, but fortunately is easier to avoid. It occurs in benign cysts and inflamed dilated ducts. The specimen is usually scanned, which is composed of inflammatory debris and scattered mature squamous cells without atypical ones. Following previous case in the previous slide, resection specimen shows dilated ducts with squamous metaplasia and inflammation. Another pitfall lies beneath the distinction between primary and metastatic diseases of salivary gland. Metastasis to a periparotid or intraparotid lymph node can also mimic a primary salivary gland neoplasm. The most common metastatic neoplasm is SCC followed by melanoma and Merkel cell carcinoma. Metastatic squamous cell carcinoma may mimic primary salivary gland neoplasm with squamous differentiation or basaloid morphology. However, you should keep in mind that primary squamous cell carcinoma of the parotid gland is extremely rare. Cytology smears of metastatic HPV-associated squamous cell carcinoma shows cohesive clusters of pleomorphic cells with high-grade cytology and basaloid to squamoid morphology. Occasional cells may mimic mucocytes, raising the differential diagnosis of high-grade mucoepidermoid carcinoma. As you can see, follow-up resection of the previous case shows an HPV-associated squamous cell carcinoma. It is also critical to make a distinction between high-grade and low-grade primary salivary gland neoplasms whenever possible, as it affects the future surgical plans. For example, salivary duct carcinoma is a high-grade neoplasm which is composed of pleomorphic tumor cells. In contrast, adenoid cystic carcinoma is cytologically low-grade but has an aggressive behavior. You should also keep in mind that low-grade lesions can undergo high-grade transformation, which is associated with necrosis and high mitotic activity. In conclusion, salivary gland neoplasms are diverse with many unique and biologically distinct entities, and their diagnosis in limited cellular TFNA and core biopsy specimens necessitates a cellular and architectural pattern-based approach. Therefore, awareness of all morphologic permutations along with updates in ancillary techniques is essential for diagnosing limited cellular specimens of salivary gland neoplasms.
Okay, great. Thank you, Dr. Parisa, for your nice presentation. And because I promised to wrap the program up in an hour, let's go quickly to Dr. Saffar. Dr. Saffar, do you have any comment or question for the second section of the paper?
Thank you so much. If it's possible, I want to ask dear Professor Baluch that when is this unique diagnostic approach for diagnosis of salivary gland neoplasms? I mean, is there any approach to first you have to do FNA and then needle biopsy, or if the FNA is diagnostic, there is no need for needle biopsy? Do you have an algorithmic approach, or you have to do the approach based on the clinical findings and radiologic findings of any case separately?
First of all, everything is kind of a little bit personalized to the patient also, right? The presentation and how the patients are presenting. I think the most common neoplasms you can diagnose on FNA if you have adequate material, which applies to an FNA. And I'm talking about common benign tumors and some of the common malignant tumors. Um, if you are on site and you're not getting enough cells, and you think, because saying something that what you're seeing on site you don't have enough, but what you're putting in the cup there's going to be more, is always wrong, right? So because what you're seeing on the smears, and you have to be very judicious on how much specimen you're putting on the smears, because sometimes the smears have everything and you have nothing in the cup to to do special studies or look further, because every stain provides a different information. To me, that is, I personally believe that. So if you think that you're not getting enough cells, I will always ask them to do additional passes. And if they cannot, because the tumor is small, I will tell them to go ahead and do a core if possible. In some areas, they cannot do a core because that is actually more harmful to the patient, because there's a blood vessel, or there's not much tissue for them to really punch in. Then I will tell them to do extra passes, and I will take that all in the cup, and I will not look at them and hope for the best. And then I will warn. So I think my algorithmic approach is to identify on site if you are looking at outright neoplasm. And at this point, I'm not worried about whether it's going to be malignant or benign. I want to create a major food groups. For me, it's something that is neoplasm, something that is atypical. That means it sits between a non-neoplastic and a neoplastic one, or something which they have, which is very important. They are seeing a lesion, and what you are getting is just normal salivary gland tissue. To me, the FNA is non-diagnostic. Okay, so they are not able to get it. So to me, that is actually very important, right? It's the guidance, like you do on frozen section. You guide the surgeon's hand, and here you're guiding the biopsy person head, whether it's you or the radiologist or the surgeon. So if I can answer those three things clearly, then I can take much more different approach on how much I. So that is the on-site. And when I look at those specimens, then I always pick up the smears first. I look at them. If I can make a diagnosis on the smears, then outright diagnosis, I don't need to go further, right? I don't need to do immunos. I don't need to do fish. But like as we know, secretory carcinomas. So then I'm already in neoplasm category, and I want to move it further. That's where I kind of start to divide. Is there epidermoid cells? Is this a monotonous population, basaloid, oncocytic? And then I go further into the diagnosis. So I think it's a stepwise approach, and you also have to tell yourself, because we get caught. We have to make a diagnosis. We have to give a diagnosis. I mean, I don't think that is actually helps the patient, because what helps is you telling yourself and what you're comfortable with, that this is a neoplasm. Here I can make an exact diagnosis, and here I can give a differential, and that's it. I mean, that's the reality, right, of it. So and there's a lot of morphological overlap, but I think there's a space, definite space for small biopsies, FNAs, to really guide the management.
Thank you. And can I ask more specifically? For example, if you are if Wharton tumor and low-grade mucoepidermoid carcinoma are your differentials in FNA smears, what's your next step? For example, do you
So
prepare
yes.
to have?
No, no, go ahead. So, I mean, I think so. First of all, if as we know, that's a very difficult topic, right? You can see mucocytes in even Wharton tumors. You can have a focal squamous or a focal, mucinous type of metaplasia in a Wharton. If I am caught where the background is not Wharton's, it's a mucinous background, there's a lot of lymphocytes, and you have to think about lymphocytes can be seen in a lot of salivary gland tumors, even actinic cell carcinomas. Sometimes even on search path, we struggle. Is this a MET in a lymph node, or this is an actinic cell carcinoma, which has a lot of associated lymphocytes with it? So we even struggle with that. I personally will make extra smears, diff quick smears, if that is going to be my differential or a cell block, and I will do fish for mammal too, because to me that really is the one that really gives the diagnosis. But one has to understand, only 68% of the mucoepidermoid carcinomas have mammal 2 rearrangements. All of them don't, especially when you are in this category of Wharton-like mucoepidermoid carcinomas or oncocytic mucoepidermoid carcinomas. So I always tell the surgeon that this is what I'm dealing with. I will do a P40 CK56 stain on this, and we'll do a mucicarmin stain, even a very special stain. I'll do it to make sure how much mucin I'm really seeing that intracytoplasmic. If there is a really good amount, then I will lean my diagnosis towards the mucoepidermoid carcinomas. And I'm very honest with them sometimes. I will tell them I have done, and I have been lucky with mammal too, because you can do it on a diff quick air dried smear, or you can do the fish on the cell block. We can do that. I mean, some people do NGS on the whole range and the stuff, but it may not be possible on the limited cellularity specimen. So I think that is my approach to these cases.
And do you also recommend frozen section diagnosis or
So I
not
mean,
after doing mammal too?
so frozen section does help, but I sometimes have seen that the frozen section sometimes is not very helpful. But frozen section at least confirm that it's a neoplasm. It can confirm how the edges of the specimens are, and if there's an associated lymph node, is it a met or not? So I think frozen section can guide in those things, basically confirming the cytologic diagnosis. But if you look at the numbers statistically, frozen sections and FNA have the same predictive value, and of the negative and a positive predictive value. So I think in some cases it may not. And if it's a small tumor, don't do a frozen section, because then you're going to destroy the diagnostic material for permanent.
And if two low-grade salivary gland carcinomas are in your differentials, for example, a secretory carcinoma and acinic cell carcinoma, both are both low-grade form in low-grade forms. Do you do you usually try to specify the diagnosis, or you just take notes and mention these differentials in your notes? I want to know that do you usually try to specifically classify a low-grade carcinoma even by doing molecular tests, or you try to tell the surgeon that this is a low-grade carcinoma, and after a complete resection we are going to do the molecular test on it, or maybe it's not needed when we have more specimen to see under microscopic examination.
So I mean, I think, remember, the biopsy is giving you a sample, so you don't know if there's a high grade component that is not represented on the biopsy. What I do is, if my differential is in a acidic versus a mucoap versus a secretory carcinoma, I always try to get a cell block and do stains, because there are specific stains for them. And IHC is really good for NIR43, or even when you dog one, I don't like, because it can be positive in a lot of stuff. And I usually don't do those stains. I always, if there's a secret, and if it is NR43 negative, S100 and hemoglobin positive, I'm pretty much sure, and GATA3, I'm into the secretory carcinoma category. I always sign the report out, and if I have a specimen, I'll do fish, just to tell them that I'm doing a fish. But so that I find really helpful. If I'm in that category, I try my best to do immunos and special stains to give them as specific diagnosis as possible.
I will share the question from Dr. Asma. Professor Baloch, do you recommend the clinician to send the biopsies with differential diagnosis, because it seems it's very difficult for them to make differential diagnosis based on just clinical radiographic correlation. What's your suggestion for the clinicians?
Well, I mean, so the clinicians I work with, they basically they know that if the tumor is hypoechoic on radiology, has a lobulated margin, is not infiltrating, they're either most likely dealing with a benign tumor or a low grade malignancy. So they always, I get that information from them. And to me, that is very important when I'm looking at a specimen. And if the specimen is not matching that, it still can be a pleomorphic adenoma with a transformation, focal transformation to a malignancy. We have seen that, and that is still confined to the tumor. But the surgery doesn't change. So for me, that information is very helpful for me as a pathologist to provide a diagnosis or create a differential. So I think it's the histopathologic diagnosis or cytologic diagnosis is actually a part of that. So I think it's important that if you see a salivary gland mass or a lesion or something which does look different than the surrounding, to do your best to get tissue for the pathologist, which can be by FNA or by core or whatever you prefer to do, or whatever your pathologist is comfortable with. But I think it's important that the pathology should be part of this, because pathology of the salivary gland tumors or lesions have come so far. Also, we know that non-neoplastic conditions are also very common. So you really, I think, the tissue diagnosis can really guide you to really have that conversation with the patients, what else you're going to do for that patient.
Okay, thank you very much, Professor Baloch. Thank you very much, Dr. Saffar, Dr. Parisa, and Dr. Maryam. And I would like to express my apologies to the audience, because we cannot share more questions in these sections. And I would like to ask Dr. Mandana for sharing the certificate of appreciation of the professors. Thank you very much for sharing your time and knowledge with us in this program. And then I would like to ask Dr. Mandana for sharing the certificate of appreciation to Dr. Maryam and Dr. Parisa. Thank you
Thank you.
for your nice presentations.
Thank you.
And thank you for your time.
Thank
And
you.
Dr. Mandana, the stage is yours.
Yes. Just a moment to say thank you to everyone. And I do hope Professor Baluch will be back soon on the channel for a full
Thank you so
lecture.
much. Thank you. Thank you, Mandana. It was great. Thank you.
Yes, thank you so much.
Thank you.
And
Have a nice Saturday.
yes, thank you. You too have a nice weekend.
My
May
pleasure.
I request you to type any of the responses you can in the chat, in the comments on YouTube, if possible for you yourself,
Oh, I will
not
do it
from
on YouTube.
here.
That's good.
Yeah,
Thank you
on
so much.
YouTube.
I'll do that.
Yes.
I'll do that.
Yes.
Thank you. Thank you,
Thank
Doctor.
you. Thank you so much.
Bye bye,
Thank you for being
everybody.
with us.
Thank you.
Thank
Bye.
you. Bye.
Bye.
Thank
Nice.
you. Thank you so much.
Thank you. Thank you.
Okay, and I would like to appreciate the audience for staying with us. And I would like to let you know that the next journal club will be held on 24th of February, and the title will be about atypical squamous verrucous lesions. And I'm very happy to let you know that we will host Dr. Agarwal. And I hope to see you all again in the next journal club. Thank you, Dr. Mandana.
You're welcome. And I think we may have to work on this paying 1.5 hour program so that we get more of the discussion going. And we will work on that. The audience, I'm sorry, I know you come here always expecting to be able to get your questions answered. But yes, today we had time limitations. Uh, but we will work on this so that the next time we have it better organized and better set, so that there is no time limitation and you can all ask your questions. Yes.
Exactly, exactly.
Right. So, with that, let me thank everyone and thank you all for being here. And yes, thank you all for being here. And let me say bye. Any of you want to
Thank
say
you.
anything, Dr. Safar?
Thank you so much, Dr. Mandana, for providing this opportunity. Thank you so much for everything
Most welcome.
and for your
You're most,
kind support. Thank you.
you're most welcome. Yes. And let me thank our two residents too for the effort that they have put in. Thank you.
And thank you too for providing me this opportunity. And thank you, Dr. Saffar and Dr. Shakib. And thank you, Dr. Mandana. And I hope it was be a good presentation.
Yes, I think we just got a comment which said very informative session. Yes.
Mhm.
So, yes. Okay. with that, let's say bye and wish everybody a
Bye.
very great weekend. Sorry, I know it's the beginning of the week for you, but anyway, for us, great weekend. For you, a good week. And we'll meet again soon. Take care, everyone. Bye.
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 Bye
Thank
bye.
you, Dr. Pouyan. Thank you. Bye.
Thank you.